So hopefully you can all see my screen, we're going to talk about the evolution of the Astra Tech dental implant system. And this is really a 30-year progressive scientific development. I noticed that many of you are both surgical, restorative, some are surgery only, some are restorative only. So we've got a good mix in the audience today. And I will try to cover both aspects, both the surgical and the restorative. So let's get cracking. And a very brief introduction to the implant was developed in 1985. And in essence, the whole fundamental start of the Astra Tech implant was a reaction, if you will, to the external hex of the original Brannemark implant. So the conical seal design became the central pillar of the new concept, and that was back in 1985, as you see. And then over the years, we've gradually progressed through surface changes, the application of microthread, restorative changes, and we're going to go through all of this, and ultimately the EV with the introduction of the new index. The man behind much of the Astra Tech implant is my dear friend and long-standing colleague Stig Hansen. And Stig and I have worked together since the early 1990s, looking at ways to optimize dental implant design. And I was very privileged to assist him in one particular area in the relation, as you see here, between surface roughness and interfacial shear strength. So this was part of his PhD thesis, looking at the role of microtextured surfaces in a world where, at the time, only machined titanium surfaces existed. And we've seen many iterations of the Astra dental implant. The one you see here on the far left is the original machined titanium dental implant. In fact, it's not quite the original, because you see the bevel at the top of the implant. That used to be a right angle, and then it eventually became beveled in the manner that we know today. But you see here different uses of the microthread, including a short-lived but nonetheless pilot-tested all microthreaded implant. And throughout the 30 years of work, certainly 25 years anyway, of work with the Astra Tech implant, what was the original fundamental pillar, the conical seal design, became wrapped in a complex of fundamental building blocks, which we call the biomanagement complex. And these include the rough surface, the microthreading, the conical seal design, and of course the connective tissue contour, or integrated platform switch, as some people refer to it. And OsseoSpeed, of course, was developed as a modified, a fluoride modified version of the well-established Hyoblast surface, which, by the way, was the very first microtextured surface on the implant market. And Stig Hansen's work and the commercial launch of Hyoblast really revolutionized the future of implant dentistry, with other manufacturers following suit with surfaces such as Osseotite from 3i, of course the SLA from Straumann, who used to have a much more macroscopically rough surface, the titanium plasma spray surface, and ultimately Nobel with their Ti-Unite surface. And I can take you back to 1991, when, together with the concept of a micro thread, which of course had also never been considered in implant dentistry before, we came up with a new concept or new design, and we have therefore had well over 2 decades of being able to follow up on the crestal bone maintenance around Astra Tech implants. And I think it's no secret for those of you out there that keep abreast with the literature that the Astra Tech implant is well recognized for its superlative ability to maintain crestal bone. And indeed, I can tell you, as probably the first audience, in fact, that I can tell, that I've recently had a meta-analysis article accepted for publication in the Journal of Oral and Maxillofacial Implants that attests to the superlative nature of bone maintenance around Astra implants. And that was based on a systematic review of many hundreds, indeed thousands of articles. So let me take you to the very first microtextured, microthreaded implant placed in a human in a private practice. This is my patient, Alison, who we treated in 1992. We still see once every 2 to 3 years. She comes in to let me take a follow-up radiograph. So the one you see, I think it was 2018. And the radiograph on your left is the original radiograph from 1992. In fact, if I were to emphasize anything, it would be the natural tooth on the left to show that it is possible, if you have a good endodontist who does good root canal therapy and apical surgery, it is possible to keep such teeth for very many years. So we're not in the business of pulling teeth out unnecessarily, because there's nothing quite like a natural tooth. But that said, when a tooth has no choice but to be extracted, as you can see from this over 25-year-old case, in fact, coming up to 30-year-old case, we can achieve great results over the long term. Many people have asked me over the years, is it the osseous bead surface, the rough surface, or is it the microthread that maintains the bone? The truth be told, the literature is somewhat equivocal on this. We do know from Stig Hansen's work that the microthreads are critical to distributing the functional loads in the crestal bone, and that may have a very powerful impact on maintaining crestal bone levels. But at the same time, of course, we know that at the micro and nanometer level, the textured surface does the same thing. So it's hard to tease out the data and know if it's one more than the other. But I will tell you all of this, that in my opinion, it doesn't really matter if an implant presents with a microtextured surface, and it doesn't really matter if an implant presents with microthreads. If that implant, for example, is a butt joint, then all of the good work that could be done by those two features becomes undone by the interface between the implant and the abutment. And so the conical seal design remains for me the critical backbone, the fundamental feature of the Astra Tech implant. That absence of micro movement and micro leakage that we've talked about over so many decades is critical to helping maintain the crestal bone levels, because when the implant surrounds the abutment as it does in a conical joint, it provides this geometric lock which gives great resistance to micromotion and therefore to micro leakage. And I can take you back to my very early work, going right back to 1997, when I did the first ever study comparing mechanical robustness between the original external hex Brannemark implant and what was then the original Astra dental implant. And we were able to show that the resistance to bending, the mechanical integrity and strength was almost 2/3 greater than the Brånemark implant. The concept of platform switching, of course, is more recent, within the last decade or so. And I would have to say that, in essence, this is a pseudo member of the group in the biomanagement complex, because I don't think there was ever any recollection that I have over the 30 years that the company said we must create a platform switch. The platform switch is an innate outcome of having an internal conical joint. It's more of an instep than a platform switch. But nonetheless, we know today that for a lot of colleagues, the concept of a platform switch, as we have with these kind of implants, is central to achieving a healthy soft tissue result. And I will focus on that a little bit later. One of the important issues, though, to bear in mind with this is the sheer volume of soft tissue and the again, the fact that because we have an internal conical joint with an absence of micromotion and microleakage, means that we get extremely healthy soft tissues with good volume and a good blood supply. And these are also key features to maintaining crestal bone. So, in essence, all of those fundamental building blocks of the biomanagement complex have been incorporated into the EV. The EV is the latest version of the Astra Tech implant, and I'm very proud to have played a central role in its development. I think the most important thing is to clearly state that it is based on the long-term biological and clinical performance that we know from the previous iterations of the Astra Tech implant. But we've tried to make it more user-friendly, more versatile, and we've tried to give it even further increases in mechanical integrity and robustness, because I think the company understood that even if it was quite rare, the problems caused by fractured components, particularly fractured abutment screws, fractured implants, is a devastating outcome for both the clinician and, of course, the patient. We also looked at the dimensions and the sort of the range of products available, because we wanted this crown down approach so that we had an implant that was designed and suited to every indication in the mouth, to optimize load distribution in the cortical crestal bone, but also to closely meet the emergence profile of the tooth in question. We knew from the TX that the original 4mm diameter implant was a workhorse, and so we started our process around the 4mm mark as a central dimension to what would become the full range of implants. And of course, I'm not going to bore you with this mathematics, but this is the equation that dictates plastic permanent deformation with fracture, and it was important to us. It was important to us to make sure that at each size of implant that we had maximum toughness. And so this led to the range of implants you see before you, from 3mm to 5.4mm. Also, we kept the tapered conical implant design in the 4.2 and the 4.8, and we have a range in profile, which we can briefly touch on later. And whilst not, perhaps from a user's point of view, for those of you that are more familiar working with TX, the idea of changing interface, it's very important that everybody understands the reason we changed the interface connection was part and parcel of trying to maximize the mechanical robustness of the implant pillar. So the EV implant is a much, much stronger implant, more capable of resisting bending moments and more capable of resisting fracture. And part of the reason for that was to get away from the double hex design inside a TX implant. But more than that, we wanted to create a double index, that is, 2 indexes in one implant. So you see here with the green arrows, this is the 6-sided index for stock abutments. And then we have a 7th slot or spline, and the 7th slot essentially provides an asymmetrical single position index. And that's what we use for our Atlantis site-specific abutments. So they are one position only. So in effect, actually, this index is 3 indexes in one, because we also make index-free components, for example, the direct abutment and ball abutments, uni abutments, and so forth. So there in effect are 2 index positions and 1 index-free position. And the different sizes of implant are offered as a guide here to the different teeth in question. So molars is recommended for 4.8, 5.4. We don't really want to see people using 3mm diameter implants in a lower molar position just because they don't want to do bone grafting. This isn't a prescription, it's only a recommendation. But these are the tooth positions that these implant diameters were ostensibly designed for. And then, of course, we've got the EV profile, which actually has a slightly different index because this now has a 5 and 6 slot, a 5th and 6th slot. So this is really designed, I would argue, principally for working with the Atlantis system. Certainly if you want to deliver the best results with the profile implant, in my view, you should be restoring them with Atlantis single position only abutments. So the index is different, and that is important to my restorative colleagues to remember, that you cannot use a standard impression coping in a profile implant. You'd need to use a profile impression coping in a profile implant. And they're all labelled accordingly. The other thing to know is that in order to help improve surgical feel, primary stability, we made a number of changes. First of all, we've changed the apical profile of the threads to give more apical primary stability in all sizes. But we've also changed the surgical protocol, which I will address. Time is very short, so I thought we'd get straight into some clinical cases. I like this case because on the right-hand side, you have no bone to the floor of the sinus. It's basically paper thin. But on the left-hand side here, you have a limited, but nonetheless available amount of bone to the floor of the sinus. Most of my cases are planned on CT scan. I won't labour that today. This isn't the forum for that. And so initially, we're going to undertake a sinus lift on the right, at the same time in this patient as placing the other implants. So here you can just see the access to the sinus. We're not here to learn about sinus lifts. Placing implants. Now, how do we help to enhance primary stability in the EV system? It's principally through what we call a stepped drilling protocol. So you can see that the initial drills, 1 to 6, all have a pilot tip in them, and they have a step on them. This means that the apical third of the osteotomy is prepped to a narrower diameter than the rest of the osteotomy. At the crestal level, you have still a requirement to use the cortical drills, because what you don't want is you don't want any pressure on the crestal bone, on the cortical bone. So in an ideal world, that osteotomy at that level should be probably the same diameter as the implant, so that there's no pressure. If you want to get pressure in order to give you maximum primary stability, you need to get that from the apex. However, there are some very dense bones out there, and you don't want to over-compress dense bone, because then you end up getting pressure necrosis. So for those, we have the X and the V drill, which allow you to further prepare the body of the osteotomy, but also the apex of the osteotomy with the V drill. So that's for the apex. And when you look at this chart, you can see that if you just use drills 1 to 6, then you have anything from a 0.4 up to as much as a 0.8 differential between the size, the diameter of the osteotomy and the diameter of the implant. So that's 0.8 is almost a millimeter, let's call it a millimeter difference between the osteotomy and the implant. So you can imagine if the bone is very dense, your implant's going to get stuck in that bone, and you'll have way too much compressive fixation. You'll end up getting insertion torques into the very high numbers. And so that's where using the V and the X drill become, I would say, not optional, but almost essential, bringing these figures down to within or below 0.5 of a millimeter. So you see with the X drill, you get it almost to the point where the osteotomy is very close to the same diameter as the implant everywhere except in the absolutely apical portion. So this is a very flexible drilling system, and it's there to assist you based on your evaluation of bone density and, of course, the degree of primary stability you feel you need to achieve. The system is all color-coded now, so you can see the yellow and the blue cover screws. On the top is the standard implant system, and on the bottom these are profile implants. And so these are very, very useful in the posterior mandible, where you have this sort of sloped ridge effect with this almost teardrop dehiscence type defect that is often created due to the sloped nature of the posterior mandible. And so the profile implant does a good job of ensuring that you don't have lots of metal and microthread protruding out of that bone. And as you can see here on the left, even if you use profile, you may still need to do a little bit of bone grafting just to cover the last little bit of exposed metal. We haven't placed an implant in the upper right quadrant because we're doing the sinus graft, so this implant will be placed in a delayed approach, because as you saw on the panoramic, he had just wafer thin bones, so there was no way that a short dental implant was going to work there, but we have used short dental implants on the upper left. Now we're moving into the age of digital, and I've started working, you can't see it, it's off screen over to my left, with the Dentsply Sirona Prime Scan. The Prime Scan works very well for 1, 2, or maybe 3 implants in a row, but for multiple implants I would hesitate still in the use of digital impressions, and most literature would seem to suggest for multiple implants that using a polyether like Improgum is still the way to go. But that doesn't mean to say that we can't take full advantage of the digital world, because the study cast, the master casts made from those impressions can then be scanned and brought into the world of Atlantis. And I've worked with every kind of Astra abutment there has ever been made since the uni abutment in 1985 was introduced, and for many years the uni abutment was the only abutment on the market. but we've come such a long way. And you know, people often ask me what have been the greatest developments in implant dentistry, and they're always expecting that I should say something about the implant itself. Well, of course, the Astra implant has had microtexturing and microthreading and conical seal design since 1991. So although we've tweaked it and we've improved it and we've evolved it, there hasn't been such a huge change in the implant system. I mean, I guess the biggest change now is the change in the index. But in the restorative aspect, what a huge change and huge impact the influence of CAD-CAM abutments, the Atlantis system, has had, certainly on my practice. And today, I'm particularly fond of the custom-base abutments, where the crowns can be cemented in the lab, and it's effectively a screw-retained crown abutment complex. So that's what we're using here. We have some bridge work in the maxilla, 2 3-unit FPDs, and in the lower jaw we've got 2 single crowns bilaterally. And if necessary, one can use, of course, the new ASA reangulating screw to get the screw holes closer to the central fossa. I like to try and make sure my implants are well placed so that that's not really necessary, and in fact no ASA screws have been used in this particular case. But we can get some really stunning results with the custom base, because we can get a perfect fit at the margin between the copings that are produced at Atlantis and therefore ultimately the crown with the abutment itself. And these are all handled in the lab. And I would make a caution, and I don't mind you seeing, for example, a little bit of a scuff mark on the gold hue coating there. We do need to make sure our labs are very, very careful in how they handle these components. But they make for a truly superb fit. And then we bring something else to the table with the EV system, which is a whole new concept in abutment screw design. So the problems that we see in mechanical failure are typically with the abutment screw. And there are a couple of issues with the abutment screw. One is the fact that they're often too thin. So, for example, that could be leveled at the TX Aqua implant, especially for the 4mm implant. We want to get the biggest possible diameter of abutment screw for a given diameter of implant. And that's what we aimed to do in the EV system. So you can see that the majority of these abutment screws are very large diameters, 2mm, 1.8, 1.6. Even the 3mm diameter implant has a 1.4mm abutment screw. And that's really as narrow as you want to be getting. But what we've also done is we've combined that with different designs of abutment screw head. So if you compare the 3.0 to the 5.4, you can see that there is a bevel here, whereas on the 5.4 it's really a flat joint. And with the bevel, the advantage of the bevel is that you can induce a higher preload across the joint, a higher clamping force. And so even though this is a smaller screw, if we use the same insertion tool, which you see down here is 25 Newton centimeters. So for the same insertion torque of 25 Newton centimeters, we are exceeding what is considered to be the critical preload of 250 newtons. And we're doing that across the range of implants. And it is no surprise, or it should be no surprise, that the one that does it best is the 4.2, because as you'll recall from my earlier comments, the 4.2, circa 4mm implant was always considered to be the workhorse diameter, the one that's most likely to be used most of the time. And therefore it made sense to give that as much of a clamping force as possible. Of course, it would be nice to see that they were all exactly the same, but that's easier said than done. The important takeaway message here is that they all cross that line of 250 newtons. This means that screw loosening should become a rare occurrence. And if screw loosening is a rare occurrence, then screw fracture should also become a rare occurrence. Of course, the days of saying that screw retained restorations are unaesthetic are long gone, because we don't have the excessive internal metal. We're using all ceramic restorations, and so you can of course see the odd screw hole here, but some of them are quite hard to distinguish, especially life size in the mouth. And here are the freestanding lower crowns on the implants with some really lovely ceramic work, I think you'll agree. And should you ever need to retrieve any of these restorations, it's very straightforward. You drill out the composite and you unscrew them. So they have full retrievability. So that's a fully restored dentition with some nice matching ceramic work in terms of color, staining, etc. And when we look at the radiographs, look, it's not a panacea. I want to see perfect bone maintenance across every implant, but I've got thousands of cases with thousands of x-rays, and of course, inevitably, some are going to look better than others. And it's interesting to see, for example, here we have a little bit of crestal bone loss, and one often questions when one sees that, did I use the right cortical drill? Should I have used cortical drill B or cortical drill A? B is probably the way to go in dense bone. Here you can see the sinus graft. Remember, this had eggshell thin bone, but we've got a nice sinus graft. And so we've got a conventional length implant of probably 11 millimeters, 9 or 11, whereas on this side, we've used a short dental implant because, yes, it is just perking through the floor of the sinus, but it was deemed unnecessary to put the patient through a sinus lift on the left side. One of the lovely things about EV now is it gives us the opportunity to effectively do less surgery on the patient. Now, that includes situations where maybe in the past you wouldn't have been able to place an implant because there was an inadequate ridge width, or maybe the span distance between two teeth was too narrow. And the 3 millimeter implant is certainly well designed to meet that demand. So here you see a lateral incisor with a massive apical cyst and a failed endo with a resorption cavity, all sorts of things going on. Now, I'm a great fan of minimally invasive surgery, so that cyst and all of the degranulation and decontamination was done via effectively a flapless approach through the extraction socket. So we extracted the tooth and we removed the cyst and all of the remaining contents through the extraction socket. We're then using Dennis Tarnow's famous ice cream cone technique to graft the socket, flip the lid of the membrane over and suture it into place. And when we come back some 5 months later, you can see there's been an excellent consolidation of the bone graft in the cyst region. We lack width though. This is very, very narrow, and even a 3 millimeter implant is looking worryingly tight in that ridge of bone. So we have to proceed with great caution when it comes to drilling the osteotomy. And again, one of the great things about the EV with the pilot drills, the step drills, is that you get really incredible stability of the drill as it's drawn into the osteotomy, because the pilot tip keeps the drill from wobbling around on the crest, which on a crest of bone like this would completely destroy it. However, we can go one better, of course, and you all know this, I'm sure. I think for these sorts of cases where space is tight, the ridge is thin, we really need to be using surgical guides. And for this sort of a case, I like to use the pilot guide. For me, it works well. I don't like fully guided surgery. That's just a personal preference, probably because I'm an old soldier who's been doing this for 30 years. But for me, the pilot guide is enough. But it's fantastic, and I'm a great fan of the pilot guide because it ensures that my initial osteotomy is exactly in the center of the span and in the center of the ridge, which when you have such a narrow ridge is crucially important. And then using the step drills, one can very carefully at very low revs, very low speed, one can gradually increase the diameter of the osteotomy. Now, most of you that know me will know I'm a big fan of immediate temporization, and a 3mm implant is no exception. I'm very happy to immediately temporize, but of course, it's always critical that these temporary crowns are clear of guidance and centric contacts. So that has to be critically appraised. And then we can go on and we can restore the tooth. Now, I liked this case because of the apical cyst. I mean, it's always nice to show interesting cases. The one issue I had is I had a final radiograph, which is a lovely result, and you can see that the implant is absolutely bang slap in the center of that span between the two adjacent teeth. But what I didn't have was a final photo. So I did ask the patient to take one with her iPhone and send it to me. So forgive me, it's not a particularly good photo. And you can see the tissues are a little bit thin, so there's a little bit of darkness at the neck, but she's very, very happy with that result. And then, of course, as I've previously mentioned, we have the short implant. Now, I have to say, honestly, that I was very skeptical about using the short dental implant because I just couldn't imagine that an implant that's only 6mm in length could support, for example, a molar tooth that might be as much as 10 or 12mm because of the vertical atrophy. And if you consider where we're going to use short dental implants, it's typically going to be in the posterior segments, below the sinus, as I showed you on the first case, or above the inferior dental nerve. So typically these are going to be restored with molars. And so you come into the whole question of crown root ratio or crown implant ratio. So I was very hesitant to embrace the short implant. Also because prior to EV, we only had the short implant in, if I remember correctly, in the aqua joint. So you have mechanical weakness and potentially implant weakness because of its short size. Of course, with EV, that all changed, particularly when considering the 4.8 and the 5.4 diameters. This is a very wide diameter implant. Indeed, at 5.4, the implant is almost as wide as it is long, and it has very thick wall thickness. So in terms of mechanical integrity, putting a big, large molar tooth on this implant doesn't present me with significant concerns. So that only leaves the fear for failure of the implant because of these excessively skewed crown implant ratios. But the good news is it's been quite a few years now that short dental implants have been on the market, and we now have 5-year or more follow-up data that shows us that short dental implants in fact work extremely well, and they work in such a good way that actually we're starting to see, the literature is showing that maybe because they're short, the way in which they impart their functional forces into the bone is actually propitious to the bone. It's advantageous to the bone. So in some respects, we're seeing better marginal bone maintenance around short dental implants than we are around longer dental implants. So you take a case like this, and you don't really have to do much, if any, surgery. This has been done flapless with a punch hole incision. We've drilled to the floor of the sinuses, which, if you've done a lot of implant surgery below sinuses, is very easy to detect when you come to the sinus floor. And we've been able to screw the implants through the punch incision and immediately connect our healing abutments. And that's it. I mean, each one of those implants takes no more than 10 minutes to do. And we can come back after 3 months, take our impressions and our shades, go back into the virtual world. Now, this actually, I should say, would be a perfect case for prime scan, but I've not had prime scan for that long, so this is a case that's probably 2 or 3 years old even. So it predates my prime scan. But this would be an ideal case for prime scan. But nonetheless, it's taken into the digital world, into the magical world of Atlantis. And again, here you can see our custom base abutments with screw access. And they are big crowns. They're full dimension crowns on very small implants. So I think caution is appropriate. But again, look at how beautifully the copings and therefore the crowns fit to the abutments. These are cemented in the lab, so they come to me as screw retained crowns. There they are with a little bit of temporary filling in the screw access holes to start with. I tend to put temporary filling in and leave it for 6 months, and then I reassess the preload. So I double check that the screw is tight to 25 Newton centimeters after about 6 months before I put the final composite restorations in. And here we are actually at 1 year. Beautiful ceramic work again by my lab with absolutely perfect color match on the staining, I think you'll agree. And when we look at the radiographs, you can see that the crestal bone is really quite superb. We are bang at the floor of the sinus here. We're ever so slightly through the sinus here, but you can see I did a little internal tenting, and you can just make out the dome shape of the tenting there. I haven't used any bone graft material, so that was just tented with blood clots. So that's why it's not overly discerning, but it's very nice to see that dome shape, which confirms that the tenting remained intact. But again, superlative crestal bone levels, perfect adaptation of the crowns to the EV index using the one position only Atlantis index. And these, I've done many hundreds now, if not thousands of these. They perform extremely well. So finally, just a quickie with the profile. I talked already about its use in posterior mandible, but it's not really that alone that profile was designed for. It was, of course, designed as an implant to accommodate the scalloped architecture of an immediate extraction socket. So when we look at a CT scan like this, we see that the crest of the buccal bone is slightly different position to the crest of the palatal bone. It's more apically positioned. because of the scallop of the buccal crest, and therefore it creates this slope. So historically, we've had a choice. If we place the implant to the crest of the palatal bone, then of course that's a disaster because we're going to have implants supracrestal on the buccal. Therefore, we have to submerge the implant to be level with the crest or even below the crest of the buccal bone. But that will place it deeper to the palatal crest and a lot deeper to the interproximal peaks. The beauty of the profile implant, therefore, is it can follow the contours of the socket and accommodate the difference in height between the buccal and the palatal, which of course is very, very difficult to demonstrate in a clinical photograph. But here you see the implant being placed to the palatal side, and this is sloping from a high point here to a low point here to follow the buccal crest, which is itself scalloped. As I say, it's a little difficult to appreciate. On the driver, you have a dimple to advise you where the scallop is. So this tells me that the slope, sorry, not the scallop, but the slope is actually toward the buccal. And you can use a non-indexed abutment like the direct abutment for this to do a temporary crown. If I'm ever in any doubt or I have any concern for the primary stability of the implant, you see that I just lute a little bit of acrylic into the embrasures just to lock that into place and make sure that the patient can thread floss over the top of these little locking keys here to keep it clean. But that just helps to lock the temporary crown in place. And here we are 3 months later, beautiful soft tissues thanks to the conical seal design and the stability of that crown abutment complex, that implant abutment complex. Now we're going to make sure we use a profile impression coping, and we can use flowable composites to pick up the internal architecture created, for example, by the temporary crown. Then we go to the world of Atlantis. Again, we see the tooth-shaded Atlantis zirconia abutments here, and in this case, it's an Emax all ceramic crown. Beautiful soft tissues with stippling, pinkness, no pocketing, bleeding on probing. Here you see a 3-year follow-up, and you can see that even with the scalloped or the sloped architecture, this implant has still been placed a little deep. That is actually my preference, and with a narrow emerging profile to the Atlantis abutment. I don't like full anatomical contour or convex emergence profile. I prefer concave and support soft tissue profile. That gives me extra volume of soft tissue to maintain the pink color, stippling, and good peri-implant health. And here, if we zoom in, we can actually see here now at cross-section how that implant not only supports the peak of the palatal bone here, but look at this. This is the peak of the buccal bone right down here, some 2.5, just over 2 millimeters buccal to the bevel on the sloped buccal aspect of this implant. So the buccal bone is actually well and truly above the implant, sitting very happily adjacent to, no doubt, some connective tissue that is attached to this zirconia abutment. And in terms of maintaining buccal bone width, you can see that the Astra implant actually does a very nice job. We have not seen much, if any, collapse of the buccal bone. And I have to say, although I accept that we will always have some buccal collapse, and there's all of that information on bundle bone and resorption. In my personal experience over 30 years doing certainly immediate single tooth implants in the aesthetic zone, it does not present a problem. And so there we go. We have the full range of the Astra Tech EV. I like to describe it as a modern implant inspired by a classic design. Most implant companies, when they want to develop a new implant, develop a whole new implant system, whether it's Straumann going from tissue level to a whole new system that was bone level, whether it's Nobel going from Brannemark, then to Select Replace, then to Nobel Active. Everyone's a completely new system. The beautiful thing about the Astra Tech implant is it is the same implant evolving over time. Modern implant inspired by a classic design. We've got some questions coming in, and I think we've got a few minutes. How does changing the index from a double hex to one hex make it more robust? Great question. Well, first of all, the EV index is not a hex. It's a six-sided spline. So it's a slot in a tube, if you will. The problem with the double hex, and if you look inside a TX implant, is that the double hex has to cut out a lot of the metal from inside the implant. That means you're thinning out the wall of the implant, making the implant that much weaker. Now, of course, I use TX for 20 years. So we all know that compared to a lot of implants on the market, it's still a pretty robust implant. So I don't want people using TX to start panicking. This is a robust implant, but my job is to help the company improve their implant every time they decide to develop it further. And this was one area where we felt there could be more improvement. The other thing about the double hex is if you look inside a TX implant, each one of those points is really quite a sharp point inside the implant. And what we know from our studies, particularly our finite element stress analyses, is that where you have very sharp corners cut out of the metal, they act as stress concentration points. So you combine thinner wall thickness with a high stress concentration point, and you run the risk of creating a crack propagation zone. With the EV index, the spline, first of all, cuts a lot less metal out and leaves us with quite a thick ring. I call it the ring of steel. Of course, it's not steel, it's titanium, but I call this the ring of steel. It acts as a bandage, if you will, around the index, giving it maximum strength. And also, because we've only got 6 slots, 7 slots in fact, cut into the metal, and they don't have those very, very sharp pointed ends to them like in the double hex, we reduce the stress concentration as well. So that's a good question. I've been asked if I use a profile EV on anterior cases. So the answer is I probably most commonly use EV for posterior mandible. I just love the fact that it gets rid of the problem of having edges of metal outside the contours of the sloped posterior mandible. So that's probably where I use it most. I mentioned that I like to submerge my anterior implants quite deep. Therefore, in some respects, it does negate the need for the profile implant. But that said, where I've got a very high scalloped contour, then I absolutely want to use a profile implant in an anterior site. Or, of course, if it's a healed ridge anteriorly and it has a sloped contour. Now, interestingly, sometimes that contour is sloped to the palatal, not the buccal. So you get a rounded buccal crest and then it slopes to the palatal. And so you can use the profile implant there, but now you're rotating it so that the slope is facing palatally. I've also had scenarios where I've had two molars where there's been an arched defect like this, and I've rotated the profile implants so that the slopes face each other. So it's a very versatile implant for dealing with sloped ridges, and that's where I've used it most. Let's see. I don't see any other questions. Mia, are there other questions that you can type? I can't see the questions coming in.
I'm having some challenges here. Maybe I can just read them to you. So Dentsply has two major implant lines, Astra and Ankylos. Can you comment about if you would use Ankylos?
Well, it's a good question, but I can't comment because I've never used Ankylos. I helped to launch the Astra Tech implant in 1990, something I'm very proud of. In fact, I actually effectively sold the first Astra implant kit in the world in November 1990 or thereabouts, on behalf of the company to a colleague of mine. So I've been intrinsically tied in with the Astra Tech system for 30 years. And that's something I'm very proud of and certainly not ashamed of. Some people say to me, well, you've never had the opportunity to experience other implants. Well, actually, that's not true. I've had a lot of experience for other implants, but from a prosthetic perspective rather than a surgical perspective. But what I will say is this. Ankylos and Astra share many, many similarities. Internal conical joints, tight seal against micro-leakage. Ankylos makes much more of a play about its subcrestal positioning, but be under no illusions. I think a lot of us in the Astra Tech world also like to go for a slightly subcrestal, maybe not as deep as the Ankylos guys, but we also like to go for a slightly subcrestal placement. So no, I don't use Ankylos, but I can see that they offer many similarities. Yeah.
Yes, and we have received another question here. Can uni-abutment be used for screw retention?
Oh, that's what it's designed for, but I wouldn't use it for a single crown because there's no anti-rotation in it. It's an index-free abutment, but for linked crowns, for linking crowns together or for bridge work, my personal view is actually that the uni abutment is still the superlative abutment certainly for full arch fixed bridge work. And in this meta-analysis that I mentioned, Mia, that I recently did, and looking through some 600-700 articles that I've done recently for another document I'm working on, I did come across a very interesting study that talked about the influence of abutment level prosthetic fixation versus implant level prosthetic fixation and how that impacts on marginal bone level and soft tissue inflammation. And there was a very clear outcome from that study that abutment level fixation does bring with it some significant advantages. So certainly in terms of full arch reconstruction, I'm a big fan of the uni abutment. So for me, that's all right. For me, it's really custom-based abutments for single crowns, or the uni abutment for full arch bridge work. When I'm doing short span bridges, I tend to fluctuate between the two, depending on the patient's periodontal status and other factors.
Yeah.
I see one here, Mia. I see one coming through now from Saudi Arabia. Hello, Saudi Arabia. What's the recommended insertion torque for the implant? Well, that's a great question, because those of you that know me know that it's a big issue for me. And I make no apology for what I'm about to say. there are, in my view, there are no reasons, no exceptions, and no need to ever exceed 25 to 35 Newton centimeters of insertion torque. I can tell you, if you have an implant inserted at 25 Newton centimeters, you can safely immediately temporize, or in a fixed restoration, immediately load that implant. To go above 35 Newton centimeters is unnecessary. Now, the Astra insertion torque, manual insertion torque tool, manual ratchet, torque driver, I'll get the words eventually. The Astra manual torque driver goes up to 45 Newton centimeters on the scale. That's very much in line with my absolute maximum. Once you go beyond 45 Newton centimeters, you are applying so much compression to the bone that you put yourself at risk of seeing marginal bone loss, or worse still, pressure necrosis. And moving on from that, if we can place implant fixture subcrestally at mesial and distal interproximal side, especially upper premolar and incisor, do we need to concern about subcrestal placing fixtures at the palatal side when the residual crest has a slope? I think it's advisable. I don't want to encourage placing implants supracrestal at any side, including the palatal side. But, and it's a very cautious but, obviously the mucosa on the palatal side is very thick, very robust mucosa, with a very thick connective tissue compartment, which itself can adhere to the rough titanium surface. So, you know, it may be if you've got 1 or 2 microthreads exposed palatally that you don't want to start raising a palatal flap to do bone grafting. But as a basic principle, my answer is you should have all aspects of the implant subcrestal wherever possible. When do I use conical implants against straight? Well, that has changed dramatically for me when I swapped from TX to EV, because for me, I was so involved in the sort of development of what was called the Astra Tech ST implant, which is the 4.5 TX, that it became my beloved implant. And so I used that a lot. But when I came to EV, one of the things that became apparent when we were looking at mechanical integrity was that the standard cylindrical implants, like for like, were always stronger than the conical implants. So a conical 4.2 is not as strong mechanically in the wall thickness as a straight 4.2. So to be honest, in the EV world, I've used less and less conical implants. The one place where it's advantageous is where in the anterior, if the buccal wall is very concave and you've got a good crest, so you can use a wider implant at the crest, but you need to taper to a narrower implant at the apex because of the buccal concavity. In those situations, I go for the conical implant. Next question, does the osteosphere surface have any impact on peri-implantitis? Well, I think the simple answer to that question is every rough surface has an impact if it becomes exposed to the soft tissue environment. Osteospeed is no different. However, I run a practice where we specialize in treating peri-implantitis for people who put their own implants in, colleagues who put their own implants in. Of course, I have my own rather substantial database of implants that I've placed over the years. And when I look at that data and I audit it, I find that, for, at least in my hands, peri-implantitis is probably running at no more than 5%. Mucositis is more of a problem, but that's true across the board. I don't accept the periodontist's approach that mucositis always leads to peri-implantitis. And I think a lot of mucositis, or what is perceived as mucositis, is actually infection or exudate coming from under the contour of a large crown, like a molar crown. It's not coming from around the implant, it's coming from between the fixed surface of the crown and the underlying soft tissues. So I've had cases referred to me for peri-implantitis where you press on the tissues and you get a bead of what appears to be pus. We drill an access hole if necessary, we unscrew the abutment screw and we take the molar crown off. And what we actually find is that we cannot probe around the implant because there is a tight fit around the implant. You take an x-ray, there's no crestal bone loss, and the suppuration is literally coming from a lack of cleaning under the contours of the crown. So I think we have to be very careful about peri-implantitis. Next question. There's lots of questions coming through now. Have you had any case when you use the VRX, the implant fails the primary stability? Well, that is, of course, a risk, that you end up over-preparing the bone and then the implant is lacking rotational stability. And I specify rotational stability because, if I can use my pen, axial stability is where the implant is just loose in the osteotomy. That is very different to rotational stability, or a spinner as we call it. And personally, I have no concern for spinners. They don't worry me at all. I put on a healing abutment, a low profile healing abutment so that it's just a millimeter or so above the soft tissue. Send the patient off. I don't give the patient any high risk warnings, never have done. These implants will still osseointegrate. One of the beautiful things about OsseoSpeed is that we know that we get a very rapid osseoconduction to the surface of the implant. And actually, if you're not putting any pressure on the bone because you've actually over-prepared the osteotomy, then that bone heals quicker. So I have no concern for a loss of primary stability in rotation if I've over-prepared the osteotomy. Now, if it's for an anterior implant that I want to immediately temporize, like the one I showed you, I just flow a little bit of acrylic into the embrasures to lock that temporary crown in place. That is higher risk. That requires very high patient compliance. It's not for the faint-hearted. So you definitely have to use the V and the X drill cautiously. But if you're inserting the implant and after, you get halfway in and you're already exceeding 45 Newton centimeters, you really must stop. Stop, remove the implant, use the V or the X drill. Because if you just crank that implant in to high insertion torques, you run the risk of getting pressure necrosis. I think we've got time for one last question, Mia. I think we're out of time. You can tell me otherwise. This question says, sometimes the 4.2 EV is too big for a premolar in the Asian female patient. I understand that. They have thin bone that makes some complication like buccal bone resorption, indeed. What do you think or recommend for this? Well, this is an easy one. You really have to drop down to the EV 3.6. And here's some good news for you. If you've been used to using the TX implant, I can tell you that from a mechanical robustness point of view, the EV 3.6 is stronger than the TX 4.0. So I
you introduced many unique features today.
Without
Which
any hesitation,
one do you find the most important
for a small premolar space in a lovely young Asian female who's got thin bone? I don't see any problems. Mia.
Which one do you find the most important one?
Well, of course, some of these features I've been using for so long that I probably take them for granted, not least conical seal design, microthread and osseous speed. But for EV, without question for me, the new index is a winner because I do so much with Atlantis. It's such a high quality restoration, which is what, you know, if you're running a high quality practice and wanting to describe yourself as a premium implant provider, then for me, the combination of an Atlantis supported restoration with an EV implant, there's nothing to beat it.
As mentioned, I like to thank everybody who's joined and listened to the lecture, as well as being active in asking questions. Thank you very much. And as mentioned earlier, we will send a recording of the presentation out to everyone who attended and who registered at the latest next week, I hope. And so thank you, everyone. Thank you, Dr. Norton, for your presentation. And I hope everybody has a good rest of the day or evening and that you stay healthy and safe. Thank you very much and take care.